Welcome again. It's Ken Wong from the RGP of Toronto, and thanks all for joining us for this webinar series. It's a very interesting topic today, actually. In our clinical training, I'm learning myself that sometimes often we're not aware of the intricacies of the legislation. So we have three speakers with us today. Judith Wahl, she's a barrister and solicitor, past executive director of the Advocacy Center for the Elderly in Toronto. Dr. Jeff Myers, he's physician and head of the palliative care consult team at Sunnybrook Health Sciences Center, and also the head of the Division of Palliative Care at the University of Toronto. And Julie Darnay, she's the manager of partnerships and communities of practice, Hospice Palliative Care Ontario, and they're actually representing a community of practice at Hospice Palliative Care Ontario on healthcare consent and advanced care planning. So we're here today to learn about this topic, and most importantly about the specific legislation in Ontario that should and ought to guide our practice. Without any further introduction, because we have a lot to cover today, I'll turn you over to Dr. Myers.
Thanks very much, Ken, and good afternoon, everyone. Thank you so much for joining us. This is one webinar in a series of many that we've been giving across the province for a number of different sectors and settings. So we're very grateful for the invitation and grateful for the opportunity to speak with you today. What we aim to achieve in the next 50 minutes or so to give some time for some questions really is to address what healthcare consent and advanced care planning, or ACP, means in Ontario, what health service providers need to know and understand about consent and advanced care planning, and then targeted and tailored to the hospital setting, what are hospitals really needing to understand to best support patients and families as it relates to both consent and advanced care planning. The key messages that we hope over the next 45 minutes that you'll really incorporate and begin to think about how they relate to your setting. That really this is a must for consent and advanced care planning to be incorporated and implemented in Ontario, and that this be in accordance with Ontario law. I can tell you that as a clinician, the legal framework in Ontario has it right. We have the conditions set up for us to do this well from a legal framework perspective, and so I really do feel strongly that we could actually do some great things in Ontario as a result. The second key message is that other provinces and other jurisdictions have very different legal frameworks, and so it's really important to not use processes, forms, policies from different jurisdictions without really contextualizing them to the Ontario landscape. So a really important point. The third point is a clinical one. I would say a clinical one, a direct clinical one, and that consent must be obtained before treatment, and that advanced care planning is not consent to treatment. So we'll expand a bit more on that. The last point is around obtaining advanced care, and in quotes, we have plans, and we're hoping that by the end of the presentation you'll understand why that's in quotes, but that advanced care plans on admission they're not of much value and much help when it comes to decisions being made about treatment in that hospitalization. So we're actually going to move on to a couple of true-false questions just to get a temperature of the participants. And so for this question, it is for a person who lacks the mental capacity to provide consent for treatment plans, advanced care planning conversations can occur with substitute decision makers on behalf of the person, true or false. So this is completely anonymous. Feel comfortable putting in your answer, and we'll give you a few seconds or minutes to do so. Got about 21 folks so far. And up to about 35. Yeah. Okay, so 33 of you, and 2/3 of you said true, and the response is actually false. So substitute decision makers can actually, just one second, sorry, there we go. Substitute decision makers can actually not advance care plan for another person. So SDMs can only give or refuse consent to treatment on behalf of an incapable person. Only patients themselves, when capable, may advance care plan, engage in advanced care planning conversations for themselves. Okay, we'll move on to the second one. And the question is, wishes for treatments should be documented in either an advance directive or a living will, true or false? Okay, we're at about 35 respondents. All right, so 75% of you have said true. And the correct answer is false, actually. In Ontario, under the Ontario legal framework, there are not actual documents such as advance directives or living wills that have a legal standing in our province. This language, the use of these terms is actually quite confusing, and we're really recommending that they not be used. In Ontario, the only part of advanced care planning that must be done in writing is if a person is wanting to name someone as their substitute decision maker that is not their automatic substitute decision maker. And we're going to get into this in much greater detail. Advanced care planning is really about communication of wishes, values, and beliefs to guide the SDM. This may be done orally or in written or any other communication modality. So these, the response of 75%, 66% true for both of these questions is very consistent with what we've found across the province in a lot of sectors, and I think represent a lot of the confusion that we aim to clear up today. So we'll move on to the content and what's in this for patients and families. I think we really want us to start with the outcome evidence for effective consent in advanced care planning, and when we are effective with these pieces, we know that satisfaction in the experience around end-of-life care is improved. The distress that caregivers are experiencing as a result of having to make decisions is much less. And I would actually point out that we're currently traumatizing people with the decisions that they're having to make. We're no longer able to use anxiety and depression scales to measure the impact of substitute decision making on people. We need to use trauma scales. When we do this well, when we get this right, unwanted investigations and interventions and treatments, as well as hospitalizations and admissions to critical care are lessened. People are much more likely to be cared for in their preferred setting, and overall, there's much less of a cost to the healthcare system. And I'm going to actually turn this over now to Ms. Judith Wahl.
So I'm going to give you a bit of the legal framework to set the scene and the things that are important to think about. So right from the beginning, I want to say that advanced care planning is part of the law about healthcare consent. So advanced care planning, though, does not equal consent to treatment. You're going to hear us saying that again and again. And so you have to think about, how does advanced care planning relate to consent? So how does it relate to consent? Healthcare practitioners must always obtain informed consent or refusal of consent before treatment, either from the mentally capable patient or their substitute decision maker. So as health practitioners, you got to talk to the patient if capable, the substitute if the patient's not capable. And advanced care planning wishes, sorry, we're having a bit of a technical problem. We're just fixing the technical problem.
That's right. It's actually just quite funny.
Okay, so advanced care planning wishes have been inappropriately used as consent when the health practitioners don't have a good understanding of how informed consent and advanced care planning are related. So if you think about it, patients can advance care plan, but these are directions to their substitute. But as health practitioners, you're needing to get directions from the patient if capable, the substitute if not. So advanced care planning is primarily messages to the substitute. So the Law Commission of Ontario has been reviewing the legislation, the Healthcare Consent Act and the Substitute Decisions Act. They've had two major projects on this, and what they've clearly stated in their reports that terminology used in healthcare consent and advanced care planning should track the language in the Healthcare Consent Act. So one of the things that we have seen from this research is that if you call it a directive, health practitioners often think that they have to do something, but that's not what advanced care planning is about. It's really directions to the substitute. Or we see in many forms the term next of kin is used, but really was at the hospital, you really want to know who would be the patient's substitute if the patient became incapable, whether temporarily or long term. So you need to get the right language in the forms to get the right answers. And then, as we've said, the terms advanced directives and living wills are not in the Ontario legislation, yet those terms appear in a lot of forms, and I think it does cause a lot of confusion. So let's give you an example of one of the forms. This is a typical hospital form that we've seen. So take a minute of looking at this. What do you identify that may need some amendment to better communicate and prompt to the health practitioners how to get consent and how advanced care planning fits in with consent?
You can feel free to type your answer in the chat box. It's at the bottom right of your screen.
So we'll go on to the showing you, highlighting some of these things. So everything that's outlined in red is either confusing or incorrect. So if you look at the top, it says patient has requested to discuss advanced directives. Well, again, advanced directives is not the right terminology, but also is it understood that what the patient should be doing is communicating with their future substitute their wishes, values, and beliefs? Does this really prompt that being done? It then goes on to say a patient has a written directive and a copy's been obtained and placed in the record. And my question when I see this is why? Well, how is it going to be used? How will it be understood? And this is where we have seen many times that people have thought, well, it's on the chart, so then we take this as the direction, as the consent, when in fact it's not. So is this causing some confusion? You may want to get that information, but how is it understood? Has the patient or substitute verbally expressed care wishes? Well, substitutes cannot advance care plan. Only the patient, when capable, can advance care plan. But ultimately, again, really what you want is the consent. So the wishes, you think of wishes are statements that are often made out of context before people understand what their condition is or what their possible treatment options are. People will express wishes that when they know the full extent of their health condition and the treatment options, they'll actually consent to something different what they wished for. So that's why it's important to really understand how these things fit together. And then it says on the form, has the physician been informed? And again, the question I have is, what is the physician going to do with this information about somebody's wishes? Is it understood that those are not consents? So here, let's look at an example of an electronic medical record that has started to put in some of the right information into the forms. So if you look at this, it asks the question, who's the substitute decision maker for the patient rather than next of kin, and it has the drop-down list of the substitutes. So this is important to include in forms to prompt people asking the right questions and getting the information about who's the right substitute. Also, what's not on here but has to be understood behind this form is what are the qualifications for substitutes. So even if somebody's highest ranking on the list, if that person is not mentally capable, then you drop them from list. You go to the next one. So you still have to understand how the list works, but putting the list in the forms is a great help to prompt people to ask the right questions. So what's required in all care settings to get this right, to get consent and advanced care right? So first of all, there needs to be an understanding of the consent process. There's been a huge amount of emphasis on advanced care planning, but we need to look at both consent and how advanced care planning relates to that. Consent always comes from a capable person, not from a document or any form of advanced care planning. Consent is really required for all treatments or a plan of treatment based on the person's present health condition. So you're not just looking at the consent when somebody is refusing treatment. You really need the consent for any forms of treatment. And you also have to understand that patients have to be informed of their health condition. There is research that shows that many patients actually don't know what their condition is, and they make decisions without the full knowledge of their condition. So they need to understand this. The health practitioner needs to explain that to them. And then the consent also has to be informed. So when you're talking about the possible treatment options, you really need to explain to the patient what are the risks, the benefits, the side effects, the alternatives to the treatment, and what happens if the patient refuses the treatment. The patient may not want all that information, but you have to be prepared to offer it to them and help them understand really what are their options. And then you get the decision from them. The decision is the consent. There also has to be a proper determination of a person's capacity for treatment decision making, and that is done by the health practitioner offering the treatment, or one health practitioner on behalf of the team that's preparing a plan of treatment for the patient. This is not done by a capacity assessor as defined under the Substitute Decisions Act. We still see this when I travel around the province. People are still saying, oh, we'll call in the capacity assessor. But it's actually your responsibility as a health practitioner to make that decision. And what is capacity? It's not a diagnosis. It's not the score on the mini-mental or the MOCA. It's a legal definition. It relates to the ability to understand information relevant to making a decision and the ability to appreciate the reasonable foreseeable consequences. So you are looking at the insight of the person as well into their understanding of their disorder. So mental capacity also should understand it's issue specific. It's for each type of decision, for each new decision. It's not a diagnosis. It's not unusual that people could be diagnosed with Alzheimer's disease yet still be capable of making treatment decisions. Mental capacity can fluctuate. It can fluctuate even while a person's within the hospital. So they could be admitted, be not capable, and then as a result of treatment, their capacity recovers. So you have to always be attuned to who are you dealing with. Is it the patient, or are you talking to their substitute? Mental capacity is also presumed unless there's reason to believe otherwise. And that last part of that line is extremely important. You can't just presume that they're capable if you see that there are indicators that they lack the ability to understand and ability to appreciate. You then must turn to their substitute if you determine that they don't really understand what's going on. And so if you find the person incapable, then you must turn to the patient's substitute. Again, why you need to understand who the right substitute is. You have to understand who is the right treatment decision maker. Is it the patient, or is the incapable patient substitute? Now, one thing I'll point out, so for example, my mom is 94. My mom is mentally capable. She is her own decision maker, even though she is a very frail older woman. She will always have one of her daughters, myself or my sister, with her when she's in a hospital. However, she is still the treatment decision maker, and you've got to turn to her because she's still capable, even though she may be relying on her daughters to assist her in making decisions. You have to understand who is the right substitute according to the hierarchy, and make sure you get that information on the forms. You also have to understand that a substitute also is not just the highest on the hierarchy. They themselves must be willing, available, mentally capable, at least 16, and not prohibited by court order or separation agreement in order to act as the substitute. So if a substitute didn't meet this criteria, you go to the next highest ranking substitute. So here's the hierarchy list. Just to clarify, I really like the fact this is a color-coded list. So because it shows you the fact that in the green is everybody in the province has an automatic substitute decision maker, even if they haven't done anything. So these are all different family members. So it's a spouse or partner, and spouse is defined as same sex, opposite sex, somebody you live common law a year, somebody you're married to, or somebody you've had a child with. Quite a broad definition. Partner is a similar definition. It actually was put in the legislation originally to capture same-sex spouses before the law had changed, but it's a relationship where two people live together, and it's a relationship of primary importance. They have to live together for at least a year. So it's not just being a roommate, it's got to have a relationship of primary importance. So then you go down the list, children. If you've got many children, all of them are equal ranking. They must decide amongst themselves who will be the decision maker. So the health practitioners can't choose amongst them. They have to choose amongst themselves, or all of them can insist on acting together. You get same thing with siblings, multiple siblings, they all equally rank. Any other relative is by blood marriage or adoption. Now, these are the automatic substitutes, but people can apply or do something to become somebody else's substitute. So somebody could apply to court. So these are the ones in yellow. The court-ordered guardian is where somebody's applied to court. The court has found the patient mentally incapable, and they are appointed as guardian. The second on that list, the attorney for personal care, when the patient, when capable, has had to do something, what they have done is prepare a document called a power of attorney for personal care, where they name somebody to be their substitute decision maker. The third on that list is a representative appointed by the Consent and Capacity Board. This is where someone could apply to the Consent and Capacity Board to be named as the substitute decision maker for somebody who is incapable. So where I have seen this application be made is where there are fighting siblings or fighting children. They can't agree on who will be the substitute. So one of them applies to the board to be named as the representative. Or another where we have seen the representative applications where somebody has a friend, and the friend knows that the patient who is now incapable would not want their family members to be their substitute. So the friend applies to the Consent Capacity Board to be named as a substitute. But all the ones in yellow, somebody's got to do something to create those. And then at the bottom of the list is the public guardian trustee. The public guardian trustee is the substitute decision maker of last resort. So if there's nobody on this list for the patient, or you can't locate these people, so they're not available, you must turn to the public guardian trustee treatment decisions unit, and they will step in temporarily or long-term to be the substitute decision maker. The public guardian trustee also steps in is when there are equal ranking substitutes. So say somebody had 3 children. The 3 children can't agree on the treatment for the patient, or they can't decide amongst themselves who will be the substitute. Then the health practitioner, by law, is required to turn to the public guardian and trustee to get the decision for the treatment for the patient. This is a good thing to know, because if you're the health practitioner, if you've got fighting families, you can say this to the family members, and that will often prompt them to start discussing and try to collaborate, because they don't want the public guardian trustee stepping in. So it's good to have that knowledge. You also have to understand that a patient, when capable, may engage in advanced care planning. So advanced care planning in Ontario has 2 parts. The first is the patient confirming that they do want their automatic substitute, so those ones in the green, or they decide to choose someone to be their substitute by preparing a power of attorney for personal care. So this is a good part of the advanced care planning, is sorting out who would be the future substitute if the patient became incapable. The other part of advanced care planning is the patient communicating their wishes, values, and beliefs about their care to help their future substitute to make healthcare decisions for them in the future when they are incapable. So if you think of advanced care planning as a patient preparing their future substitute to be able to step into their shoes, to be able to step in to make the decisions in the way that they would have wanted if they were still capable. That's really the core of advanced care planning. It's also important to understand that substitute decision makers cannot engage in advanced care planning. And as we saw from the poll, we know that this is one of those things that people misunderstand. I think one of the things why there is this misunderstanding is people often think that DNR is advanced care planning, but it may not be. It could be something that somebody's consenting to. So if you think about it, a consent is is a decision in respect to a treatment related to the person's present health condition. So if people are at end of life, they're extremely frail, where they would not benefit from resuscitation, the patient themselves may be giving a consent to no resuscitation, or the substitute, if the patient's incapable, can step in to give that consent. So it's not just because this is a treatment taking place into the future. If it's relevant to the person's present health condition, then it's a decision that's made, not an advanced care plan. Think of advanced care planning as speculative. It's the what ifs. If this happens to me, then I may want such and such. You're speculating. But consent, you're making a decision based on relevant information that's current. So that's the distinction. You have to understand also the relationship and the differences between advanced care planning, goals of care, and informed consent. And I'm going to turn over to Jeff to explain that to you now.
Thanks, Judith. So I think what Judith really nicely started us out with was an overview of the key process elements for advanced care planning. And what I want to take the next few slides is and talk about advanced care planning and consent, sorry for Judith. And what I want to talk about are a little bit more along the content. What actually is the information from advanced care planning conversations and decision-making conversations that will help facilitate these processes in the most meaningful and effective and purposeful ways. And this slide, I think, we came across this, and thanks to Dr. Nadia and Cardona for this slide, because I think it encapsulates really the crux of the content for these conversations. How a person makes healthcare decisions is two parts of an equation. The first part on the left are a person's values, what they consider to be important to them, what they have as goals for their care, what's meaningful to them. And it's in the context of healthcare decisions, a person can reflect on these elements and sort of hold that as one part of the equation. The second part of the equation, the right side of the equation, is the evidence, is the information. It's the facts and figures that we have about specific healthcare decisions. And unless we bring both the person on the left and the treatment and the disease on the right together to make healthcare decisions, then we're missing the boat. And I would say that that's probably the greatest challenge and the greatest gap when it comes to decision making, is our jump to focus on treatments and information and evidence around those treatments, and forget about the person, and forget about that there's a person that has a sense of values that is the information that would actually be helpful to substitute decision makers when it comes time to, if it comes time to giving consent. So another way to kind of frame this as a larger sort of process over time is I often get questions, especially recently, around what's the difference between advanced care planning and goals of care discussion. And this is the way that palliative care folks anyways think about this, is that, as Judith has outlined, advanced care planning conversations really are speculative about a future context, and that information from advanced care planning conversations ideally is used by SDMs to guide decision making in the future if that's necessary. Goals of care discussion really is what happens when there are treatment decisions or care decisions that need to be made. And a goals of care discussion is a precursor, in my view, to decision making or consent discussions. And what goals of care discussions do is ensure that the person side of the equation is adequately represented. So when I say goals of care, I'm saying what are the person's goals for their own care. I think that our rehab colleagues have always gotten this right on their view of goals of care. But I would say in my interactions with a lot of my colleagues in acute care, for example, they're equating goals of care with decision making, and we're losing the person as part of the equation along the way. So if we really think of goals of care as what are the person's goals for their care, what do they value, what's important to them, as critical information along with the treatments and the evidence around the treatments to make decisions together. Okay, so and apologize for the warping of the font here, but this is sort of a word description of what I've just outlined, and distinguishing or comparing and contrasting the three different discussions, in that the outcomes for advanced care planning conversations would be a prepared SDM in terms of future consent and decision making. The outcome is not, for advanced care planning, something like a code status or a POST, as Judith has mentioned around the code status. POST is an acronym that stands for Physician Orders for Life-Sustaining Therapy, and is a standardized set of orders that's used in a number of states across the U.S. as decisions that have been made by a person. Now, a POST would not really pass the legal test, I would say, or test the legal framework here in Ontario, but it's often referenced in various Canadian documents, and so we put it up here very deliberately to say that a POST is not an outcome of advanced care planning. Goals of care discussion. The outcome for that would be that the patient understands their illness, which I'll come back to in a moment, but that the clinician and the teams really understand the person and their values and the goals. Code status is also not the outcome of goals of care discussion, nor would a POST be. These would really be what we would expect from the decision-making element of this piece. In terms of how goals are defined, I've already touched on this, in that it really is the persons to define and describe for both advanced care planning and goals of care discussion. And in decision-making discussions, the treatment orientation for goals, I think, is appropriate because we're needing to shift to actually make practical, concrete decisions. But I did want to come back to the outcome is for the goals of care discussion and underscore the point around patients understanding their illness. I cannot emphasize enough how critical this piece is. The percentage of patients that have life-limiting illness that fully appreciate that their disease is not curable and progressive is astonishing. So, very concrete example, so a number of studies saying 80-85% of folks with metastatic cancer don't appreciate that their cancer is not curable and is progressive. So people are making decisions. Another example, really quick actually, is folks on dialysis. Very high percentage, 65-70%, believe that their dialysis is curing or healing their kidneys. So people are making decisions based on this information. And it's not that we're not giving them correct information. It's complex in that people may not be understanding the information that they're being given. So health literacy is a huge issue and directly relates to the ability to ensure that consent is informed. So then what are helpful advanced care planning conversations, and some very specific advice and suggestions around this? So we often hear commonly used phrases on the left side of this table, like no heroics, or no machines, no tubes, or do everything. For the no heroics, no machines, and no tubes, I would want you to think about it for a moment. For folks that say no heroics or no machines, is that ever? Or is it only when there's no chance of recovery? What if there's a 90% chance of recovery? Would a person be okay with temporary use of heroics or machines? So even just with these couple of questions, you can see how a statement like that is actually not very helpful to an SDM when interpreting when there's a context that's added in. So cut to a future when a SDM has been told no heroics, no machines, but is then being given probabilities around the kinds of recovery that a person might be expecting. So for the tubes, again, what if the circumstances were short-term and reversible? Would a tube be acceptable? For statements like do everything, which is kind of the opposite of no heroics, no machines, it's important to think about this for a moment and really, what does this mean? What state of being is the aim here for us to achieve? And more importantly, how will an SDM know when everything has been done? And this really, I think, speaks to some of the trauma that we're seeing with SDMs when people are wanting sort of, quote, do everything. When will an SDM know that everything's been done?
So more helpful information, like when I get these statements, no heroics, no machines, no tubes, do everything, I get excited because for me, that triggers 14 more questions. They're a great place to jump off from and really explore, why does a person have this perspective? What's happened? What are their experiences that have brought them to believe that they do not want heroics or machines? What is it about a tube that makes a person not want one? That's the information that gets at the values, the underlying values for some of these, and that's the information that would help an SDM, because that information can be applied to a number of different contexts and a number of different spins on the way that these treatment offerings might surface. For the context of do everything, the question I ask people is, what would it mean to not do everything? What is it? What are the underlying fears or worries that come to mind if we didn't do everything? And then how do we approach reconciling this? Because the reality is that we're not getting out of here alive. And so what would it mean how might this look in a very practical way? So these statements, although I would say they're not helpful, they're very helpful from the perspective of them being a springboard to delve further and get at the actual information that would be helpful for a person. So to summarize the outcomes of an ideal consent and ACP conversation is that the SDM is aware of a person's values, what the person views as a meaningful life. The SDM begins to understand how the person might make decisions and how they view benefits and burdens. The SDM has the information that will guide decision making and avoids the statements that we've outlined without modifiers that would make these situations bearable or unbearable for the person. So it's the conditions under which a tube would be acceptable or unacceptable, bearable or unbearable, tolerable or intolerable, based on sort of whichever word makes sense to the person. So then coming back to this outcome evidence, this was not always the case. So when advanced care planning was first pursued as an entity, I think back in the 50s or 60s, the approach was very much an advanced decision or advanced directives, and we learned quickly we didn't learn quickly. We've not applied the information quickly. That information around specific treatments and decisions is not helpful, and there's clear evidence that advanced directives actually do not impact outcomes. However, when we shifted focus towards a person's values, that's when we started to see this outcome evidence emerge. So this was not always the case. What's changed is that we're focusing more on the person, who they are, what's important to them, what matters, and that's how we're actually achieving the outcomes that we need to. My last slide before turning over to Julie is just a couple of important points about advanced care planning to remember. What's key is the information, and the role of the SDM is interpreting any form of advanced care planning that the patient has completed in the past, but most importantly, it's the most recent information that is really needs to be guiding the SDM the greatest. Really encourage you to promote an understanding amongst your staff that advanced care planning documents or statements are not to be used as direction for treatments, except in an emergency. Right. So when an emergency, then they can be used as guidance directly to the healthcare team. And then really quickly, the DNRC forms, we often get this question, so we put this bullet up here. DNRC forms are not the same as consent to a DNR status in the hospital. So DNRC forms were designed specifically for first responders, so firemen or
ambulance.
Paramedics. Sorry, firefighters or paramedics, for when they come into a person's home or their dwelling and see that something needs to be different about this person in terms of a decision that has been made for that context. That decision, though, is not applicable to other settings. And so if a person is brought into a different setting with the DNRC form, it's really important that a conversation occur with either the capable person or their SDM to ensure that remains the case. Move on to Julie.
For folks typing in questions, we encourage you to continue asking questions to our speakers by typing in the chat box. And we haven't forgotten about you. If you asked a question a little while ago, we will scroll back and address all questions at the end of the presentation.
Thank you, Ken. The very last section of the presentation is really dealing with system strategies to help get this correct. So I'm going to go through this very quickly so that we will have time before 1 o'clock to address the number of questions that have been posted. So this particular slide really looks to how we can improve quality and effectiveness of healthcare consent and advanced care planning in Ontario. And we really believe it's a culture shift that must take place in order for this change to happen. And we've identified these 4 elements, which we recognize are minimum considerations for really the successful implementation of a healthcare consent and advanced care planning intervention. And these 4 elements are completely interdependent, meaning that the effectiveness of one is really dependent on being effective with each of the other 3. The education element and the distinction between the necessary public education efforts that enable self-management, as well as the challenge of achieving and measuring competence among clinicians, is also extremely critical. And while standards have not yet been established for what defines competence, ideally, clinical skills, quality improvement are all linked with patient and family outcomes, and therefore the most effective way of really changing culture and behavior among clinicians is really obtaining direct feedback from patients. The next slide, we really have just developed a model to help people looking at how healthcare consent and advanced care planning is currently being used within organizations and institutions. And what we are suggesting is if such activity policies, practices, guidelines are in place, we really do suggest that they are reviewed to determine whether they are meeting the legal framework for Ontario, and are they evidence-informed practices? And if so, then that's wonderful, and we really recommend ongoing quality improvement efforts. But if not, actively facilitating course correction is necessary. If no such attention is currently being paid, then we really are strongly recommending getting on board and setting clear expectations, and again, ensuring compliance within Ontario. As a community of practice, we also recognize that this is an extremely hot topic at the moment. Many forms are currently in development, and therefore it is a matter of informing and educating again to ensure that this is being done correctly, and we will provide you with numerous examples to help you in that development effort. So Hospice Palliative Care Ontario has a healthcare consent and advanced care planning community of practice. It was really created to respond to the need for resources for healthcare consent and advanced care planning utilizing the Ontario legal framework. We support everyone from clinicians, administrators, caregivers, policymakers, etc. in this community of practice. Our goal is really to reinforce the link between healthcare consent and advanced care planning for healthcare providers, and Hospice Palliative Care Ontario hosts the work of this practice. The next slide is just really a visual of the community of practice. It's multi-layered, consisting of a leadership advisory team that really is comprised of a diverse group of experts in legal, policy, clinical, operational, knowledge translation, implementation of healthcare consent and advanced care planning in Ontario. We have regional champions across each of the 14 LHIN areas to help that local implementation of initiatives. We have just beginning a new organizational champions group to really help supporting individuals within community long-term care hospitals to become champions to help that change management practice within organizations. And we have a broad community of practice that's now exceeding 100 individuals that are coming on to really just understand this better and to participate with the community of practice in a regular way through many of the educational opportunities that we have available. Next slide. We have several working groups, but one in particular that I wanted to bring to your attention is a hospital working group. And the scope of this particular one is really to develop best practices for healthcare consent and advanced care planning, and it's supposed to be hospital, not long-term care resources, to support positive change and practices across hospitals in Ontario, to incorporate it in a knowledge translation approach through project activities, best practice theory, and translation of practice, and to ensure sustainability. We've got a very active work plan and are working with a number of key partners in the province, including the Senior Friendly Hospital Initiative and Northern Ontario School of Medicine, and are partnering with the OHA and the OMA with this particular initiative. So there will be a number of different resources and probably a very specific section of our website that will come in the very near future to help support specific initiatives in hospitals. This is our Speak Up Ontario website. We have an advanced care planning workbook for patients on the site, both an interactive online mode, as well as a downloadable version and a hard copy version. We've also outlined a number of healthcare consent and advanced care planning toolkit, which can help you do a review of your policies, guidelines, procedures, tools within your organization. And these are very, very helpful resources that can help walk you through that process, as well as a planning tool that helps to outline common themes and errors that we have commonly identified. We've also provided you with a key list of Ontario references. Often when you Google, you will get resources that are taking you outside of the province or often outside of the country. So we do really strongly advise you to ensure that you are looking at an Ontario-specific resource, and this is certainly a place to start. We also, on our website, have a repository of examples of projects that we have been working with and resources that meet the Ontario legal framework. These are 3 in particular that I strongly advise you go to the website to have a look at. One is an ACP conversation guide produced by Dr. Jeff Myers, who's with us today, and Dr. Nadia Incardona. Waterloo Wellington has an amazing project of ACP education program, Conversations Worth Having. And the East Toronto Health Link has also produced a number of different brochures, workbooks, CPR brochure, SDM brochures, wallet cards. So as opposed to starting from scratch or reinventing the wheel, again, we recommend that you highly look at these resources, and I know that their authors are more than willing to share this information. We have, as Jeff said earlier, this is a series of webinars that we are offering. So this was our 2016 sessions that we have archived and that are currently available, as well as our 2017 education series that's currently available. So anyone who may have missed today and may want to pick up one of these upcoming opportunities, that's our date, and you can get further details about this by contacting the Community of Practice. I've also provided you with the link to become a member of the Community of Practice. We also offer a resource review through the leadership team. And if anyone is interested in this, this is the link that you could go to find out more about our resource or our review opportunity. So just in summary, I just wanted to conclude with it's extremely important from a systems perspective that we work collectively to clarify confusions, dispel the misconceptions, and to correct these incorrect practices. Provide accurate knowledge of the Ontario legal framework and encourage consistent practices. Expect accurate language, which promotes clear communication, and discover and utilize Ontario-specific resources. As Jeff has mentioned earlier, 100% of people will die in Ontario. Therefore, consent in ACP is relevant to 100% of Ontarians. Therefore, it's not a matter of if we get this right, it's now a matter of how and when we get this right. So ideally, a coordinated effort at provincial, regional, and community levels is required for success. So thank you very much. And this is contact information for the Community of Practice should you have additional needs or questions beyond this webinar.
I want to reassure you that the slides and an archived recording of this webinar presentation will be sent to you along with the evaluation. But right now, why don't we scroll back up and begin to answer the questions that accumulated over the course of the talk.
Sure. So thanks very much for folks that have sent in the questions. I'll start and I'll read them out loud if that's okay. The first one I think was here. So if a patient is capable to make decisions, in the event I become incapable to make treatment decisions, I want person A to act on my behalf, but this is not supported by a power of attorney, and the person is not the highest ranking SDM, how do we respect the request?
You can't respect the request. So what you do have to do, what you can do is tell that person that what they would have to do is to create a power of attorney. That's why it's important that you understand that process so you can prompt people to do what they really want to accomplish. But by law, you must turn to the highest ranking substitute in the list.
Okay. Next question. What has come of the report that you were working on, Judith, for best practices on advanced care planning goals of care forms in hospital? And if possible, can a copy be sent?
That paper has been released. It's on the Law Commission of Ontario website. So if you go to their website, to their end of life project, and in the paper, the writers were myself, Mary Jane Dykeman, and Tara Walton. So you'll be able to easily find it there.
It's a fantastic document. I encourage folks to go through it.
And I will acquire that link and send it along with the evaluation package.
Okay, next question. Is there a conflict of interest in advanced care planning where children who are excluded from the power of attorney financial, as they may benefit from the estate, may be the best person for POA, but similar conflict of interest are related to treatment decisions as SDM influenced by estate issues? What is the best practice for ACP goals of care forms?
Okay.
Yeah, I know.
So it's not considered a conflict that the adult child who is going to be making treatment decisions, it would inherit from the person.
Okay.
So that's not considered in the law. However, I'm going to say that this is something that's a live issue that health practitioners might want to look at, because if when a substitute is making a decision, we didn't talk about this in the webinar, but they are required by law to follow the wishes of the person expressed when capable, if the wishes are possible and if they're applicable to the particular treatment decision. And if they don't know of wishes that are applicable, they're to act in their best interests. If you identify as a health practitioner who's seeking the consent that the person is being influenced to, like, say, example, refuse a treatment because they are going to financially benefit, you could make the argument that this person is not acting in the best interest. Yeah. You are still the advocate for the patient. So there is a formal process called a Form G application where you apply to the Consent and Capacity Board to have the board review whether the substitute is acting in the best interest of the patient. So that's something to keep in mind, but that's where that conflict may be captured, and it's important that you are an advocate for the patient in those circumstances.
It's a great question. And then the second question, what best practices for advanced care planning and goals of care forms?
This is a tricky issue. I'll let Julie talk about the resources that are on HPCO website. But one of the things that we found in that research study we did for the Law Commission of Ontario is that we reviewed 100 sets of forms. And I'm going to say that not one set was completely legally correct. There were some very good elements in many of them, but it was clear there wasn't a good understanding of consent and how advanced care planning related to that. So it's important that there be reviews of the forms and documents they're using. I'll let Julie talk to what HPCO is doing, because it might lead into give you some other ideas.
As Judith said, we really believe that a cookie cutter approach is not appropriate here. And so our hospital working group is really looking at an environmental scan of what we are recognizing as some best practices in the province. And so through that knowledge, we will be focusing in on some of those projects for broader implementation across the entire province, as opposed to it being unique to any individual hospital. So this is a kind of a work in progress and an ongoing piece. We are hoping that we will have some tangible tools, templates, that will be available within the next couple of months.
I'll ask the question just around, because I know that some provinces have a provincial form, different kinds of forms, and wondering if from your review, Judith, if you think that's ever possible for Ontario or appropriate.
I actually don't think that will happen. Governments are not really like to create a form anymore. That used to be old law. They've taken away those standard forms, and for good reason. It's because it was stifling creativity. It wasn't getting people to really look at the individuals involved. Some of these things have to be tailor-made to people. In the Law Commission report that I did the research paper on, that was actually one of the questions we were asked, is could there be a standard set of forms? And we actually said that there can't be. And the reason we felt that is because so many people are working on healthcare consent and advanced care plannings. Like, you've got clinicians, you've got researchers, you've got lawyers, everybody thinks they've got the magic bullet.
Yeah.
And so I think instead, and we also see people are influenced by many different players. So, if you're a health professional, you've got your professional bodies, but you've also got the place you work at. It goes on and on. So what instead the approach is can we get the basic principles that have to be kept in mind? And this gets back into HPCO is looking at potentially creating some templates to guide people. And then you can, if you follow the templates, you can create very good documents, but then you can also tailor make them to your practice, to the kind of work that you're doing, to the types of patients that you have.
And the other thing I just wanted to add about that, because it was sort of a planned question, I know your response was going to be, but the other piece to add is that it makes room for the person, right? Like yes. I think that lots of times part of the challenge around standardized forms and templates is we lose that person, we lose that person's value, the person's values in terms of the decision-making and consent processes. And that really is critical for the success of any kind of informed decision-making process overall.
Mm-hmm. If I could just add very quickly please. To that, Jeff, and if there's an urgency by any of you on the line to review any of the documents that following this presentation you feel may not be compliant with the law, please approach the community of practice, and I can direct you to some resources that can help you in that review process, as well as allow the leadership team to even do a final, it's not a legal review, but more of an educational review that can kind of help you guide that development.
And then the last question was already answered, actually. DNRC, the acronym does stand for Do Not Resuscitate Confirmation Form. The C, there was just a question as well.
And I concur with Jeff. I think this form has been misunderstood. You have to understand the reason it was created is because emergency responders cannot make decisions about whether to offer resuscitation or not. They are actually required by law to resuscitate. So the DNRC form is actually a direction from a health practitioner to them to give them permission to not resuscitate. Yeah. So that's why it's significant, and that's why it has to be reviewed. It's really meant for transport only.
Yeah. Thanks, Judith. Thanks very much. And I'll turn it over to Ken.
Thanks very much for your attention. It is rounding 1 o'clock, and this is I think we'll all agree, a great presentation. It's something to be very mindful of and to keep our knowledge fresh so we can continue to be thoughtful at pursuing what's right in these very complex issues. So I will end very shortly, but just point out that you will receive a quick evaluation survey by email, all those registered to attend this webinar. Please share your suggestions and topics for future sessions. And along with this evaluation, a link to presentation slides and a recording will be provided. I will work a little bit to dig up the links and resources that were brought up during this discussion and send them to you as a package as well. We do have a future webinar booked on April 25th, the Music Project, a program based on evidence showing the benefits of music and stimulation on people living with dementia, and the Alzheimer's Society of Toronto will come to visit us and present that. We are also penciling in a webinar for the end of March, and please stay tuned. You're all on the mailing list, and you'll receive information for that future webinar as well. But without any further intrusion on your day, I thank you all for attending. Thank our speakers for this very lively discussion and for keeping our thoughts provoked for the rest of the day, because we do need to be very mindful of all the intricacies to this area of practice. Thank you very much.